Today is May 24th, 2016. Kay Wagner is talking with Dr. Philip Doescher, a retired radiation oncologist. Dr. Doescher did his residency at the University of Minnesota or South Dakota and then transferred to Minnesota, correct?
Yeah, med school was Minnesota and South Dakota, and residency was Minnesota.
Okay. And then he joined Gunderson Health System in 1980, and what year did you retire in?
4 years ago, probably 11,
Okay.
2011.
Well, welcome, Dr. Doescher. We're glad
Thank
to have you here. And Jay Chautka, Medical Media, will be doing the taping. First of all, please tell us about your family history, where you grew up, your education, and training.
I grew up mostly in Sioux Falls, South Dakota. I went to Augustana College in Sioux Falls, then I went to I went to School of Mines in Rapid City for 2 years after that in physics, which was a dead end. But not being real quick to figure that out, I went towards a PhD in physics at Iowa and realized there's no jobs. I really shouldn't do this. I need to find something else. So then I started deciding what to do, and I was really frustrated. I remember that. I just didn't know which way to go. And I talked to my dentist and said, I was thinking of going to dental school. He said, let's go to med school. And it never occurred to me in a million years. I thought, yeah, well, I'll look at it. And I did. And I had to take some prerequisites. Back then you needed a whole bunch of prerequisites which have nothing to do with anything, but that's what they did. And finally, after getting those accomplished, I finally started med school in probably 1971 or 2. And did 2 years in South Dakota, 2 years in Minneapolis, and then I stayed there for my residency. So,
What did your father and mother do for a living?
my father sold feed for livestock, and he managed farms. This was 100 years ago, and my mother's a homemaker. And I had 3 brothers.
And what did they go on to do?
My brother is a CPA, and he worked for Good Samaritan. He's still in Sioux Falls, in fact, and retired. He's about 7 years older than I am. And the other 2 were unfortunate. One was schizophrenic. He killed himself at age 21, which is just the most awful disease known to man, is schizophrenia. You can get cancer and you die in a few years, and that's okay. But if you have schizophrenia, you don't die. You just torture everybody around you. It's just god-awful. And my other brother had Down syndrome, and he really was a fun person on this planet. Life was good. It was great. He couldn't do much, but he always had his things he liked doing, and he always was happy. And there was such a difference. You know, if you get to pick one, pick Down syndrome. Schizophrenia is just not even. It's just, you can't fix it, I guess. Maybe now there's better things, but. So it was a pretty traumatic life for my parents, I think, with what they were dealing with too.
Right. How did you decide to become a physician? You talked about that a little bit, but was it your father's suggestion?
No.
The light bulb went off?
No, nobody even suggested. I think it's just kind of I didn't know what to do. And I always say you fumble your way through life, and I sort of blundered into this thought and thought, well, it looks like it might be a good career. I really didn't know anything about it. And so it wasn't like I was driven toward this all my life. It was just sort of happened, I think, more than anything. And I really feel lucky I fell into this, actually. It was a good career. I like what I did for a living, and I felt good about it. So it was okay.
Why did you choose radiation oncology?
Actually, I had started out in OBGYN at the University of Minnesota, and that was a residency that, in my opinion, wasn't compatible with life. You were on call every 3rd day. You go there at 7:30 in the morning, you're up all night, you never saw a bed, and you're back in clinic 7:30 the next morning, and every 3rd night you did that. It was awful. I pretty much decided I was going to drive a truck for Sears before I was going to do this the rest of my life. And so I knew I wasn't going to do that. Although the doing that was was okay. It was just the lifestyle was so horrible that I didn't like what I had the hours I had to spend. The surgery part was fun. I was really good at that. You know, I could do that real well, but it's just the hours. And I think I saw the staff guys up walking around at 2 o'clock in the morning when I was on call. I never saw a better. I thought, man, this isn't going to get any better. so then I happened to spend a lot of time with the people having radiation therapy. But back then, the University of Minnesota was a big center for treating cervix cancer, which used a lot of radiation therapy, and I got to know that department pretty well. And actually, one of the staff there, we're looking for another resident, and I thought, wow, maybe this is what I should look at, and I did. Just fumbled into that one too, I think. But anyway, that was just pure good luck, in my opinion, because it was a good choice for me. I loved what I did, and it was very, very rewarding, and I would do it all over again. I tell a lot of people when I see medical students, I say, you should look at this. It's a good life. And so I guess that's how it happened that I blundered into it.
Was there a particular mentor or role model during your residency and education?
Yeah, there really was. Roger Podish was just incredible guy. He was a radiation oncologist at the University of Minnesota, and I really thought the world of him. I think, you know, my goal always be like Roger. So it was neat having somebody that was so incredible and so brilliant and worked so hard. So I think he would probably be my role model.
How did you first hear about Gunderson Lutheran?
When I started looking for jobs, I kind of looked in just the Midwest, and I only looked at two places. One was Omaha and one was here. And I didn't know anything about Gunderson Lutheran. I don't even know if I'd heard of it until then, but anyway, when I came down and got to see what was here, I was really impressed, and they offered me a job, and I thought, this is great, it's where I want to be. Had the kind of small town that I liked, and so I think another place I just really got lucky and fell into the right spot.
Were you married at the time?
Yeah.
Mm-hmm.
Yep, I'd been married from probably 2 years before I even started medical school. So my wife got to live through all that trauma with me.
And she has enjoyed living here as well?
Yeah, I think this has been good. She likes this place.
How many clinicians were here when you joined the clinic? Do you remember?
148.
140?
That was me.
That was your number?
Yeah.
Isn't it? It's amazing to me that everybody knows that.
Yeah.
I mean, it's.
Do they still number them? I don't even know.
I don't think anymore. My understanding is that it was more for accounting purposes, or than it was, you know, counting up the number of people. But I'm not sure. 148. And you were among the first non-Gunderson members recruited. Was that challenging?
Oh, I didn't even know that was true. I mean, I saw there's half a dozen Gundersons, and I was 148, so it just seemed like I was in the majority of non-Gundersons. But it didn't change anything, and they were all really pleasant to work with from my point of view. I loved them all. You know, they're really neat people, and they really were. They're a really incredible bunch of guys.
Well, radiation oncology has evolved considerably since the 50s, 60s, 70s, and 80s. What, in your mind, is the greatest innovation that you've seen in the field?
Oh, there's so many things that happened. The technology has advanced so much with imaging, MRIs and PET scans. We can see things we couldn't see before, and if we can see it, we can hit it. There isn't anything we can't hit if we can see it on MRI. And we can treat weird shapes. We can treat a peanut in the brain or a horseshoe around the spinal cord. And we can just hit those spots very precisely, and because we're such good shots, we get more radiation than we used to get and not get in trouble. So So we've come a long ways in making a difference there. It's still the bottom line is you have to find it early, and then there's some cell types are worse than others. But if we find them early, we can fix things we used to couldn't fix. And the other thing that's changed is combination of chemo and radiation. There's a lot of things that the two together work much better than either one alone. So that's really made a difference on cure rates for many kinds of cancers, lung cancers especially, and lymphomas and GI cancers, all the main ones. It's really made a difference. And the other thing are probably implants, that little seed implants in the prostate, for example. I did probably 1,000 of those, and they were really very successful, very good way to go. That they gave an intense dose to the prostate without getting anything in the surrounding area, and the local control was extremely good. In fact, we had 7 out of 1,000 that when I looked at it one time that had failed in the prostate. And that's less than 1% failure rate. So it's a very good way to treat prostate cancer. So there's things like that have really made a difference. There's a lot of things we did that kind of died on the vine. There were mammal sites where you put a radioactive source right inside a cavity in the breast, and they were okay, but I think it's kind of traumatic and a big deal to do that, and it turned out it didn't make that much difference, and so it's kind of a dead issue now. And we used to use radioactive stents for cardiac restenosis. When they do a cardiac stent, they'll expand the blood vessel, and sometimes it'll plug up again. And if they know that's going to happen, they'll put a radioactive source right into that area, and then it might prevent it. Well, there's better ways to do that now with chemicals, but anyway, that was kind of an offshoot of some of the things we did at one time. But the most significant thing is the way we can do things. It's called IMRT, intensity modulated radiation therapy, and anybody that's been through radiation therapy has probably heard of IMRT, and it's a way of come to focus on a spot from 7 or 9 different angles, for example, and just really hit that precisely. And by doing that, we can treat a head and neck cancer and spare one of the parotid glands, which is the worst thing we do to people is head and neck cancer. It's easier to have a heart transplant than to have head and neck radiation therapy. But by sparing that other parotid gland, it says the misery is just definitely less. And we can do things like stereotactic radiation, treat a small lung cancer, something the size of a marble or a golf ball in the lung. We can focus on that from 7 or 9 different angles, and almost always destroy that completely, more than 90% of the time. And people don't even know it's happened. They come back 2 months later and they didn't know if you did anything. And it's a very successful way to do it. It's not the standard of care for lots of cancer patients for lung cancer, but it's done a lot. And especially somebody who's not a surgical candidate, we can see a spot and just blast it and it goes away. And so it's been a really neat way to fix some cancers where you can't do surgery. I think those are the big things where we really can focus and see things and hit targets we couldn't hit before. And it's because of the imaging and the radiation techniques that they've developed over the years that can do that stuff.
The usual course for radiation time course is six weeks, I think. Has that been shortened by technology, or is that still the standard?
Oh, it's pretty common. It's a lot of times with prostate cancer, it's 8 weeks now.
Okay.
And part of that's because we're better shots. We can give more radiation than we used to give. It's the same amount every day all the way through, but because we can give more, it takes a little longer, and because we give more, it works better. So it's 6 to 8 weeks would probably be more routine now. And it depends on what you're trying to accomplish. If you're just trying to make some pain go away, you can do that in 10 treatments. But if you're trying to cure and give the absolute maximum amount of radiation with the best effect, then you stretch it out longer. It's a little safer and it works a little bit better. So. But that hasn't changed much. There's a lot of things they've tried. They tried 3 days a week, and they tried 7 days a week, and that didn't work. 3 days a week, it's just people couldn't tolerate it, and 7 days a week is too much, and they couldn't tolerate that either. So So we're back to 5 days a week, just fine.
Moving on to your tenure at Gunderson, were you involved here beyond your clinical practice, like boards or committees, medical education, research, outreach?
Yeah, I was in a lot of those things. Our TOG is Radiation Therapy Oncology Group. There are several things throughout the country, like the pediatrics have a group, medical oncology has a group, radiation therapy has a group, and they get together with the smartest people in the planet, and they all sit down and try and decide what the best way to give radiation is, or a combination of radiation and chemo for different diseases. And they would have 150 studies going at one time. And there'd be 2 arms to the study. We didn't know which was better, so you'd flip a coin, and somebody get one treatment choice, and somebody get another, and then wait 10 years and see who won. You do a lot of work to answer one little question, but that's the way it works. And anything else in research is pretty much an anecdotal story. Well, this guy did that, and look at his results. Well, that doesn't mean anything. You got to have a big national study to really confirm what's the right way to do it. And so it was a big project to be in RTOG, and you had a lot of hurdles to cross, but it was a good thing. And I was on education committees and cancer research committees, but mostly that was probably the biggest thing, was the RTOG.
I saw that when I was doing a little bit of research.
Yeah.
That site came up.
Yeah.
Well, Gunderson has a strong history of medical education and research. How did medical education and research affect or enhance your clinical practice here?
Well, I think I learned a lot. I'd go to all those conferences, every one I could go to. And one of the unfortunate parts, I didn't realize on Tuesday morning, Ed the old Overholt, gave a conference, and it was incredible. And so 2 years before he retired, I was at every one of those. And they were just great. I wish I'd known about it before, but I went to every noon conference I could go to, every medical oncology conference. They were all great. You'd learn all kinds of different stuff. And some didn't apply to you, but it was still interesting. And so that was really valuable for me to be able to go to all those conferences. And the one I probably did the most is every Tuesday at noon for 35 years that I know of. It was a urology conference, and I went to that all the time. And I always said I knew more about kidney stones than any other radiation oncologist in the world. And it was fun to go to it. Those guys are all my friends. It was a good thing, and it was just turned out to be a wonderful experience to go to that urology conference. And I never missed. I went for I guess I was here 30-some years and never missed that conference. It was just standard part of my Tuesday noon. I always did that. So I have good memories about a lot of the conferences I was able to go to. But that would probably be my favorite one. It's still on every Tuesday at noon. In fact, we get done by noon today, I'll go to it.
You're a loyal donor to the foundation, and for that we thank you. What motivates your ongoing support?
I think it's people helped me back in the years when I had no money and no way of making things, and you don't forget that. It was wonderful that they were able to that happened. I would have been in trouble without it, and so I feel like it's a good place to donate money. It goes for a good cause, and at least I feel like I know where it's going to. So it's a good thing.
On a more personal note, what would your colleagues say that you are known for?
I do a lot of trap shooting. A lot of my friends and I shot with them. They would know about that, trap and skeet, and and my hunting trips. So yeah, I do a lot of hunting, and I guess that's one thing. I have a lot of bonding with a lot of people here because of my hunting and shooting. And I do a lot of woodworking, so I have my group of friends that do woodworking, and as far as outside of the work, that kind of thing is what I do. I used to ride my bike a lot, and have a group of friends you ride with too. So there's things like that.
I asked Dr. Eric for his memories, and the first one was the hunting. Besides describing you as a stalwart in the radiation oncology department here. So he knew about your passion for hunting.
Yeah, I did a lot of that.
Do you have a favorite story about Gunderson? A miraculous day, proudest day, a patient that you remember?
You know, there's a lot of stories. Some of them are just, there's this one patient. It was a young lady who all she wanted to do was get pregnant, and she had developed a melanoma and had axillary nodes from it, and it was bad. It was really bad news. And she had gone to the tanning booths and got it. And she was young, pretty, hardworking, and had a neat husband and neat job. You know, just the nicest person in the world. And you know, she needed radiation. They said, well, whatever you do, don't get pregnant because you're getting all this radiation exposed to you. And she'd been trying for years, so she can't happen. You know, and sure enough, she got pregnant. And the big worry is she had a lot of bad cancer, and she was likely to develop metastasis. And the metastasis crosses a placenta like 20% of the time or more if you have metastatic disease. And so this was just really scary. It's just this baby could be born with the same disease she has, you know, if that happened. It turned out that the last I heard, everything was wonderful. She had a normal, healthy baby. She did not have metastasis, and things were good. But it was just horror, you know, what could have happened to her. And, you know, it just scares you to think of some people, what they go through, and, you know, it's just what a chip. Life isn't fair. Mm-hmm. You see that so many times. The hardworking, honest people that don't do anything wrong get clobbered, and you know, why does that happen? I just don't understand it.
It's good that this had a successful outcome.
Yeah, that one did. As far as I haven't heard lately, but at the time it was good news. But you know, you just think about it every day.
Anything else that's a favorite memory about Gunderson?
Oh, I think probably the best is all my friends here. You know, I really felt like this was home, and I got to know a lot of people and really had a good time with my fellow workers. And it made it easy to come to work and made it fun. And so that was probably maybe part of the reason I feel so good about my career is I had a lot of people here that I knew, and and I felt good about the patients too. I think what my style is get to know them, ask them what their hobbies are, what they do for a living, who their family is, and you almost always have something in common with some of them, and that makes it real special. You can just, did you get any ducks this weekend? You know, and so it's not just talking nothing but what their problem is, but it made it real special to get to know people.
How about any words of wisdom to offer a young physician entering medical school today?
Well, that would be my best advice, is get to know their patients, get to know what they like, get to know something about their family and their, you know, it's easy just the facts. You know, we can do that without knowing anything, but I think people really miss out if they don't get to know more details about who this person really is and what they're going through. And you can do that in my specialty because we would see them every day quite often for many weeks, so I got to know them really well. And that made it again, this is a good career, whereas every other physician you look at see somebody once a year or whatever, you know, 5 times a year, but they don't have the time to spend with them. And so it's been another reason this has been a good career for me, is I've had time to get to talk to people and get to know them. And you don't have that when you got a 20-minute slot. You got to get it done.
That's true. And what are you doing now that you're retired?
Well, I goof off a lot. I still do a lot of shooting. I was just shooting my shotgun this morning, and I'm still doing locums. I do locums in the cities. I work about 1 week a month, and that's been fun. Actually, it's not like having a real job, but it's been really fun. And I've known a lot of those people there. When I was a resident, some of them were still there. In fact, when they called me and asked me if I wanted to do this, I said, "Oh, I don't know. Oh, well, I'll try it." So, and it's been really a pleasant thing to do. They're happy to see you. You go fill in for a few days and then you leave, and it's a pretty easy life. And I still get to do some things. You know, it's not like doing everything, but it's still, you get to do a lot. So that takes about 1 week a month, and then the rest of the time I'm really good at goofing off. I got a lot of hobbies and a lot of friends, and it's been the best part of my whole life is after I retired, because I can play more, and I'm really good at that. So.
Do you go to the breakfasts or lunches that they have at Diggers?
Sometimes, yep. Once in a while, I know it's a kind of a long drive for me now, so I don't get there as often as I like. But I always like going there and seeing those guys again. And but they're all kind of special to me because I spent my whole life with them, so I really enjoy seeing them again.
Is there anything else you'd like to share that I haven't covered? Want this to be about, your story and your memories, and these are just general questions, but if there's anything else that you'd like to share.
Oh, nothing special, I guess. I think this has been, it's just been a wonderful place to be from my point of view, and for a career. But I guess I've already said that, but it really is. It really has been wonderful.
Do you have anything else you'd like to include in your file? I know I've got your resume or your curriculum vitae. Is there anything else that you'd like to have us include?
No, I don't. Not that I can think of.
Okay. Well, thank you again for taking the time to come here today. I appreciated that.
It's kind of fun to come back and see what's going on all the time. See people that I know. So I always look forward to, I can't even walk down the hallway without seeing somebody I know. And in fact, I would have been here sooner if I had ran into somebody I know. But it makes it special to come over here all the time. But the other thing's all the new faces, all people I don't know. Oh my gosh. I used to go to the conference and I'd know everybody. Now I know 1/3 of the people. So that's really changed.